So that little exercise is fantastic, and as I said, whenever we start a class with my patients, or not necessarily my patients, anyone who attends the program, we always do that, and typically at the end of our program we repeat it, and we look at the movement patterns, and the patients can see the movement patterns from before the program and after the program, and they are entirely different. Black and white motor patterns. The motor patterns are derived from the brain, the central nervous system, and it is essentially like a roadmap from your brain to your muscles, and the pathway that is taken at the beginning of the program is completely different to the pathway that's taken at the end of the program. And that's what it's all about. So I'll just start by talking about, just re-emphasise that neurosurgery is really a cutting edge specialty. It's really at the forefront of technology and advancements, and there have been amazing advancements in neurosurgery since I started my training. But in terms of sheer numbers and sheer effect on patient outcomes and morbidity, there is nothing that I've seen in my professional career that has had more impact on patient quality of life than functional movement training and movement therapy that we've implemented in the last 5 years. And as I said before, this was not taught to me as a trainee. Okay. So what do we want to achieve with QAS, patient transport officers and staff? Our primary objective, of course, is to prevent injury. Okay? That's always going to be number one. Not just spinal injury, but shoulders, knees, hips, neck. That, of course, is ultimate. Global injury prevention. There's going to be times, it's unavoidable, people are going to get hurt. They're going to twist their ankles, they're going to jar their backs, they're going to be in a rush, and they're going to get injured. And in that scenario, we want to promote optimal recovery. Okay, we don't want people off work for months and months. There's a lot of secondary sequelae that happens to people when they're not working and when they're in chronic pain. What are our secondary objectives? Well, we want to build their functional capacity. Okay? And functional capacity that exceeds functional demands mean that we have a robust, resistant to injury staff member. And that then flows on, it's a spectrum, that as we build that robustness, we actually start to build athletic staff and fit staff. And the definition of fitness is really about work capacity, which as an employer, that's really valuable. If you have a staff member that has very good work capacity, that's a valued asset. And we can define fitness by work capacity, and work capacity across a range of activities and a range of time domains. Defining fitness in terms of the way that sport defines fitness is a little bit misguided. If you define fitness as in, I can swim 100 laps of the pool, I can ride a bike fast, I can run fast, that really does not define fitness. That defines someone who's a good swimmer, a good runner, a good cyclist. But defining true fitness, and true fitness relates to health, it is about work capacity across multiple activities, across multiple time domains. And that is scientific. It can be measured and calculated according to physical principles, which are force times distance. So the force you apply, the distance you apply that force, and the time duration that it takes you to apply that force. The time, when you implement time, that reflects the power of your individual. And in the motor car industry, that's really important. People are going to buy a truck, a car, or a vehicle that has a certain amount of power and a certain amount of work capacity. It's defined. We can define that in the human as well. And NeuroHAB will ultimately create a fitter, healthier athlete that can be defined scientifically. So, what are the tasks of QAS officers? I'm introducing this term GPP, and that stands for General Physical Preparedness, and it is very much comparable to the military, the Defence Force, firemen, because the tasks that your staff are faced with may be very heavy, they may be slow and light, they may be in intervals, they are going to be dealing with variable terrain, stairs, corridors, driveways, wet ground, dry ground, loose ground, and awkward positions. So really, an ambulance PTO, patient transport officer, has to have a high level of GPP, general physical preparedness, and that's how our military focuses on their officers, their soldiers. They need to be ready for any challenges. And I looked up some of the information that Kevin forwarded to me, and I was staggered that it's not uncommon for you guys to have to deal with a 150 kilogram bariatric patient. He sent me a manual. You've got patients on stretchers, you have to reload stretchers, you have to put things on roofs, you've got to climb upstairs with patients in wheelchairs. And all of these things resonated very much to me, that your officers have to be ready for general, for GPP, general physical preparedness. So how does FMTC, or Functional Movement Training Centre, meet these objectives for you? Well, we have a fantastic team, and our team members are cherry-picked to be the best. Myself as the leading clinician in the team, and understanding from a medical perspective the spine and the biomechanics of the spine, and what surgery and modern medicine can do for the spine. We have exercise scientists, we have physical trainers, Olympic weightlifting coaches, and functional fitness coaches. Every single person in our team has a unique and distinctive focus on transferring the lifelong skill of movement proficiency to our patients. And that's an essential component of our practice, is having that, I think Loz alluded to it, that coach's eye, that understanding of what good movement is and what bad movement is. And in our exercise at the beginning of the talk, I'm sure all of the coaches here can pick up on the deficiencies that were evident when you guys did that task. So is movement proficiency important? My God, it's imperative. Okay, it's imperative. Movement proficiency is key and fundamental to safely building functional capacity in spine health. And the lack of an emphasis on movement proficiency in clinical musculoskeletal practice is probably the sole reason why medical care is failing miserably to control the tsunami of musculoskeletal disease. In the Australian Bureau of Statistics, back pain and spine pain rates economically as one of the biggest burdens on Australian taxpayers. It's on par with heart attacks. Okay, so it is in the top 1 to 2 economic burdens for the country. So if we're going to deliver a premium method and obtain premium outcomes, we must bridge the gap between these common therapies here. Now, in principle, there's absolutely nothing wrong with physiotherapy. There's nothing wrong with going to boot camp and getting fit and sweating it out. There's nothing wrong with these commonly employed methods to manage musculoskeletal pain. But in isolation, they will not effectively deal with back pain. Okay, that's the cold hard facts of the literature. So why does functional movement therapy work in a distinctive way over other therapies? It works because it does bridge the gap. It's unique and it's simplistic in its methodology, but it's simplistic only because it's refined down from very complex clinical and scientific foundations. If you think about all the patient injuries that we see, and I think you mentioned about 70 injuries last year, how individualised those injuries would be. The location of pain, the age of the patient, the predispositions, what that patient perceives as having caused their pain, the different therapies that they may have tried already. It's very complex. But at the heart of all the physical spinal disability is movement dysfunction. And this is an example of an algorithm taken from a low back pain textbook that tries to sum up in a slide how you've got to manage someone with back pain. And if you try to manage your patients like this, it's doomed to failure. And there's a principle called Occams, the Occams razor principle, that if we have a complex problem and we have a complex method of solving it, the success rate is likely to be poor and the efficacy poor. Whereas if we have a simple problem, a simple generic implementation of treatment, our success rate is going to be high. And this is how I've synthesized that data, is that patients will present with these different types of pain symptoms. So they may present with discitis symptoms, and these are all clinical, well-recognized symptoms that I deal with every day. Facet joint pain, myofascial pain, bursitis, and all of them are downstream problems. The first domino that falls over in the vast majority of patients is movement dysfunction. So if we then stop focusing our attention on all these complex presentations of pain that require complex and multiple and varied solutions, and just switch our focus to movement dysfunction, we then develop this type of paradigm with a high efficacy and a high success rate likely. So what does the back pain research in current practice reveal? It really is failing dismally, yet conventional approaches are not really changing despite the poor clinical efficacy, and continue to employ this dripping tap principle, which I'll elaborate on in a second. But if you look at this, 1 in 4 patients at any point, 1 in 4 people at any point in time will suffer back pain. Their lifetime prevalence is well over 80%. It depends on where the data comes from. And this is really interesting, that if you have an episode of back pain, there's a 75% chance that within 12 months you're going to have another episode. And that resonates, that the thing that caused that back pain has not been addressed. Your back pain occurs, it might occur for 2 weeks, 3 weeks, 2 days, but then it comes back again, and that should not be the case. It should not be the case. If you had a plumber come out to your house to fix up your tap, and he says, "Look, I'll fix your tap up, but it's definitely going to start, leaking again within the year," you'd probably get another plumber. Okay? But yet, when it comes to back pain, that seems to be acceptable. 10% of patients who have back pain don't get better in a few days or a few weeks. They go on to chronicity. Okay? And once you have experienced pain for 3 months, there's some fairly significant physiological changes that happen in the nervous system. And that now transforms that patient into a much more challenging patient to manage. And that process is almost like another disease on top of the injury. That's called central sensitization or centralization, when pain becomes entrenched in the nervous system, and it becomes very difficult to pull people out of that scenario. And we talked about the economic burden. Now, what's this dripping tap principle? Many physical therapists are lost, and I get letters like this on a regular basis, at least 1 a week, from a physical therapist that has told me about their back pain patient. I've tried intensive manual therapy, I've tried deep tissue massage, I've tried joint mobilizations. He still has back pain. And I'm even doing strengthening of his back and core, even though he has a 6-pack. Okay? And what they are doing is just turning the tap tighter. Okay? Here's the painful drip. And instead of actually changing the washer, they are just twisting this tap tighter. And eventually, you can't twist the tap any tighter. Why is the prevalence and recurrence rate so high? And that alludes to your question earlier. So on a global scale, the recognition of the disease that's causing the symptoms is poorly defined. And without a definition of the disease, developing a cure and prevention is impossible. You're doomed to failure. All we can do is just keep trying to turn that tap tighter, and that is really what's happening out there. What is the evidence, further evidence for this? This diagnosis here, I see it all the time in medical reports, in work cover, insurance claims. Defence Force officers who are discharged, they have back pain. They have permanent incapacity because of low back pain. That is not a diagnosis, okay? That is not a diagnosis. And that would be like me going to the doctor and him telling me that you've got shortness of breath disease or you've got headache disease. I would want to know why I have shortness of breath. I would want to know why I have a headache. Do I have a brain tumour? Do I have inflammation of the lungs? And it would never be accepted in other fields of medicine, but in musculoskeletal medicine and the spine industry, we wholeheartedly embrace these diagnoses that aren't really diagnoses. Back pain is a symptom, it is not a disease. And I'd like to talk to you about degeneration, evil degeneration. We always talk about our pain is because our spine's degenerated or it's old and rusty. Facet joints, black discs, I hear this all the time. The patient sits there, I actually say to the patient, why do you think you've got back pain? It's because of my black disc or because of my bulging disc. Guess what? This is normal. Your spine is allowed to age. Degeneration should not cause pain. If it does, then we better all get ready for agonising face pain disease. Okay? Does that make sense? That as we degenerate, we don't all start screaming about our facial pain because we've got some wrinkles there. It's normal. Okay? The spine is the same. The spine is part of your body. It is allowed to degenerate and it should not cause pain. Conventional treatments. Okay, the centrefold of the Australian newspaper not too long ago. So this would be quite typical of your injured PTOs, right? You give them a bit of rest, bit of time off, maybe some restricted duties. You give them, the doctor would give them some tablets. They'd go and see a therapist. Any number of different types of methods are implemented. They may, if it's really becoming a problem, go and see a pain specialist who would, and I work with pain specialists, and they would maybe up the ante on the medications, increase the potency, dosages that would put me to sleep for a week, but they can tolerate them because they've already been on lower doses. They escalate them. Injections, burning nerves, it's rampant. And then they'd come and see a neurosurgeon. Okay, and that's typically when I'd get the patient. After all of these things have been tried, and then it's like, whoa, what do? I've only got surgery, and this is what the epiphany was for me 5 years ago, was that I really don't think you need surgery, but yet you are a completely broken human being because of your pain. And what do you notice about all of those common things? Okay, they all address symptoms. Okay, all address symptoms. None of them addresses what caused the problem in the first place. So our mantra is to treat the disease, not the symptoms. And the disease is movement dysfunction. And what does movement dysfunction do to the human body? Okay, if we continue to move our body in our lives with a level of movement dysfunction, it does increase the substrate of degeneration. So if I MRI patient X who moves well at the age of 30, they're going to have a certain amount of degeneration. If I MRI patient Y who moves poorly, their degeneration will be worse. Neither of those patients may suffer back pain at this point in time because their functional capacity is meeting their functional demand at that time. But what does having a lot of degeneration do? It does open the window to injury. So continuing to move poorly will transform this degeneration into painful degeneritis. Okay, so if you have a lot of degeneration, then the likelihood of you transforming that degeneration into degeneritis, which is painful, is high. Whereas if you have minimal amount of degeneration, you're a little bit safer. And so you really do want to maintain your degeneration at low levels. And how do you do that? You maintain good movement proficiency lifelong. What happens when you start to feel pain? We start to maladapt. Okay, we start to maladapt. It's like going on a hike and having a pebble in your shoe. Okay, if you're feeling that pebble in your shoe, you're going to start to walk slightly differently to take the pressure off that pebble. And what does that do? That then causes more movement dysfunction because you're now not walking properly, and at the end of the hike you think, why the heck does my ankle hurt? Because the pain caused a maladaptation. What you should have done was stop, take your shoe off and get rid of the pebble and then continue, right? But that's what happens when movement dysfunction prevails, is that you enter this cycle of movement dysfunction which causes pain causes a maladaptation, and then further movement dysfunction occurs, and then the cycle repeats. And chronicity of this cycle will lead to this steady decline in functional capacity. And now when you go to pick up the cat or put something in the dishwasher or pick up a patient, you've got this window of risk that develops the injury in your individual amount of degeneration that exists in your spine. And the injury occurs when the functional capacity is less than the functional demands of your job. And we've already shown that the functional demands of a PTO is very high. So you guys have to have a high level of functional capacity. And this slide just is a bit of a graphical representation of like a bushfire scene where it's high fire danger. The substrate of degeneration is high. It doesn't take much for someone to just drop a little cinder and boom, we have a massive raging, burning pain and fire. Whereas if our degeneration was very low from good movement, someone drops a match, the grass is green, it's moist, it's damp, nothing happens. Okay, so you've got this element of protection. This depicts the functional capacity and demand seesaw. If this tips the other way, where your demand is high and your capacity is low, bingo, injury window open. And the cycle where movement deficiency leads to pain, pain leads to more movement deficiency, cycle. And often our modern lifestyles, which is in the big scheme of time, sitting in chairs, driving cars, catching elevators, having bags with wheels on them, it's this modern lifestyle that we're bringing into our society that is driving the movement deficiency in the first place. And unless we actually recognise that and try to eliminate that, then we are very much doomed to entering this pain cycle. And as the stats show, 80% plus of people will experience back pain in their lives. So we have to have a rigid definition of what good movement is. And over the years, I have synthesized the key points of performance that we look for and that we're trained to look for when it comes to rehabilitating patients or preventing patients from having injuries. And it really does boil down to 5 simple points of performance, and we call that the NeuroHAB screening test. And guess what? You guys all did the NeuroHAB screening test at the beginning of our talk. Hip-centric rotation, and Loz will go into this in much more detail later. Hip-centric rotation, neutral spine maintenance, because we know from biomechanical studies of the spine that in the neutral position, the integrity of the facet joints, the integrity of the discs is maintained. The moment we drop out of neutral positions, we are then increasing the stress on those structures. It's like squeezing an orange seed, you know. If you think about squeezing an orange seed in between your fingers, if you're dead on in the middle and at the top and bottom of the seed, it's not going to go anywhere. If you slightly go off neutral and you squeeze, the seed's going to fly off the one, and that's a disc prolapse. That's what happens in a disc prolapse. Posterior chain activation. The posterior chain is all these muscles and ligaments and tendons and joint structures that run up the back of our spine. We have to activate our posterior chain, because where does the spine live? At the front of the body or the back of the body? It's at the back of the body. So it makes sense to have the conditioning at the back of the body, the posterior kinetic chain. Unloaded knee positions, okay? Unloading the knee, because otherwise if you load the knee, the next thing your officers are going to start to complain of is knee pain, and that's going to cause maladaptations and further movement dysfunction. Satisfactory range of motion. Of course, we have to have the range of motion that's required to get down and pick up a patient, or to pick up a stretcher, or to pick up a gas bottle. And functional movement training is really about brain training, okay? It is a software fix. We are rehabilitating the nervous system, and that's where the term NeuroHAB is coined. It's a nervous system rehabilitation. We are not doing exercise training. We are not doing boot camp. We are not doing PT. Although it may look like that, as we said at the beginning, by maintaining movement proficiency, unavoidably your staff will become more athletic, more fit and stronger. But that's not the sole focus. And a lot of exercise physiology programs such as planking and Pilates and core stability programs, it's all about you've got to get stronger muscles. We're not worried about stronger muscles. Having stronger muscles and moving poorly is just as bad for you. Because all it means is that you've got strong muscles moving your spine poorly. Okay? We focus on the software, which is the brain. So, most importantly, the movement proficiency that we employ in everyday life has to be transferred, not just in the workplace, but when we brush our teeth. If you're a toddler, when you pick up the toys. If you're an athlete at the gym, breaking a world record, picking up the groceries and picking up a barbell, right?
He's a good looking rooster.
If you X-ray these people, their spine would look identical. The toddler's spine will look identical to the Olympic athlete. And before this toddler has enough time to develop movement deficiency, it happens naturally. It's programmed into our DNA. It's only modern society that ends up corrupting those motor patterns, and then they start to do crazy things like this, which is completely unnatural. And when was the last time you saw a toddler get up onto his toes and pick up a toy car like that? They don't. They do a proper functional movement. And this type of training will not work. Symptom-based treatments, anti-movement-based treatments, stretching and exercises that do not focus on movement proficiency will never achieve the results that I want for my patients, and I'm sure that you want for your staff. And here's another letter, physiotherapy, Pilates and strengthening, and yet it's having an impact on sleep patterns, but he continues to have severe low back pain. But he's already tried the conventional things for months and months and months. And I think I'm on to my last slide. I'd just like to show you this. I hope it works. So, 2 patients, 2 years of therapy, 6 months of therapy before I saw them. Both under insurance companies. Look at their movement patterns. They're in pain, they're maladaptive, they're dysfunctional. They're starting movement therapy now. You can see the movement transforming, it's becoming more fluent. He could never do that prior to commencing movement therapy with all of the multiple therapies that he had. This lady was so scared of moving, so scared of moving. She didn't know how to move properly once she developed her injury. And after 6 weeks, she said, "When can I go back to work?" It's all because the focus is on movement performance, proficiency of movement. And it doesn't matter how old or young. Everyone needs to move well. And they then become athletes. They go from being my patient to being normal to becoming physically athletic and fit and healthy. Just because we focus on the foundation of health, which is movement proficiency. That's one of the four pillars of health is movement proficiency. All right. Thanks very much, guys.